occlusal plan can be get. Okay, so CAD designed virtual setup and temporary denture. So this procedure, this time point process give us a good information, the teeth size and the midline and occlusal plan. All this information is very important factor to make a final restoration in case of full edentulous areas, full edentulous mouth. So after that, we can make this printed denture. This 3D printing denture is very useful and versatile. First, actually, this printed denture using as a surgical stand for proper positioning when you have a surgery point. And after that, we can estimate and evaluate the prosthetic procedure. Before the final restoration, we estimate and adjusting all these teeth position and vertical dimension, and if possible, if we need, we can adjusting all this situation. So we can get the final restoration with the perfect situation. Okay, and when you get this 3D printed denture, this denture, the working as a surgical stand, making a hole like this one, and when we have a surgery, this stand, this 3D printed denture, using as a surgical stand. And preparing all these the informative surgical stand and the temporary denture, the 3D printed denture is very essential part. And after that, into the patient mouth, extraction and the implantation. In the same time, simultaneous approach will be available, or a little bit delayed approach also available. And actually in this patient, the extraction, whole jaw, the whole teeth of the jaw, upper and lower, and the lower jaw, immediate implantation was performed, and upper area, 1 week later, implantation was performed. Okay, the lower jaw situation like here, after extraction, cause of lower jaw, actually only 4 implant will be planned. So number 43 and 36 area. It means seemed like Oron 4 concept. However, this implant installed the parallel. Whole 4 implants was installed parallel. Okay, so during the surgery, when the surgery performing situation, Dr. Chung used bright tissue level, diameter 3.59 millimeter, cause of vertical bone height was available, enough. Dr. Chung chose 9 millimeter length tissue level implant fixture. However, diameter little bit squeeze to 3.5. 3.5 diameter, however, very similar strength and working as a 4.0 bone level implant fixture. And 4.0, 9 millimeter on the molar situation, molar site. And after that, osteon collagen as a bone graft materials inserted the defected area. And the anterior area also osteon collagen. This one is a collagenized graft materials, brand new graft materials. Source is the xenograft. And coupled with the collagen graft 2, the cover above the top portion of genocollagen and the suture. Very simple and the practical surgical procedure was done. And the post-op is here. For implant installation, the planned area. Healing 1 week situation here. Number 46, 33, 43, 46 area. All these areas get the perfect implantation. Looks like a textbook-like situation. And before the surgery, upper jaw, we can see the maxillary sinus rheumatization. So Dr. Chung want to prohibit he don't want to have a sinus surgery, big sinus surgery, cause of early loading for the patient. So he got the little bit, the anterior implantation was planned. Number 12, 14, 15, 22, 24, 25 was planned. And after 1 week extraction, intraoral site situation is here. Actually, he didn't suture after extraction, so just only 1 week. We cannot see the stitch. Okay, the surgery plan is here. Implantation on number 12, number 14, number 15, and 22, 24, 26. The 6th implant was planned. At this time point, you want to have a bright tissue level. And also simultaneous GBR procedure using osteogeno collagen, osteon 3 collagen, and collagen graft 2. All these biomaterials for the simplified GBR procedures, the essential part, make it easier GBR procedure. Okay, so today's surgery point is here. Implant positioning using printing temporary denture from all the informative data, the 3D printed denture using as a template, the surgical stent when he have surgery. Before surgery, making a hole on a perforating jaw according to the data from the CAD program. Okay, as you know, osteogeno collagen combined with the collagen binder holding the osteogeno xenograft material. This xenograft from the bovine, the collagenized bone, very similar to osteon 3 collagen. However, the osteon 3 collagen is osteon 3 particle. The alloplastic graft material, osteon geno, the xenograft materials, is one big thing different. Okay, the collagen graft 2 is a totally different materials from the collagen membrane. Actually, as I mentioned earlier, this collagen graft 2 promoting faster soft tissue healing. So actually these graft materials, the graft 2, these the collagen materials working as the barrier function also have a promoting soft tissue healing. So we can use this graft material on the ridge preservation, the porcine tendon source, type 1 collagen. And bright tissue level, the many times already is introduced from me. Actually, this tissue level implant, the built-in the screw abutment style tissue level implant, the external connection type. Okay, let's move to today's surgery. Okay, as I mentioned before, this 3D printed denture inserted into the patient mouth and checking We have to check intimacy, the adaptation, by adaptation of this 3D printed denture into the patient mouth, cause of reduce the gap between the actual situation and the planned site on the computer program, right? Checking, and we made a decision. We make a decision using this 3D printed denture is useful for surgical stand or not. I think this denture have good informative result, and Dr. Chung using as a surgical stand this printed denture. All of these dentures came from the digital procedure, right? As I mentioned earlier, how can you achieve this kind of the printing denture? The file, the matching each other, intermingled each other on the software program from CT STL and intraoral scan STL, and the actual patient soft tissue, hold this reference point, and using the reference plan used for the matching each other information. And from this data, we can make the proper positioning in future, the proper prosthesis. Okay. The making a hole, making an indentation without the before the incision. Okay, the expected implantation point was drilled using this surgical stent, the actually 3D printed denture, using as a surgical stent. The whole area was inserted by inserting pin, checking the pass and the position, the parallel pin. I think the position, almost the exact, like as the computer programming, like as a planned site on the computer program. Okay, and he is starting make an incision using number 15 scalpel. Okay, the planned site was 12, 14, 15, right? 245, 245. So he is making the incision line a little bit palatal, the palatal inclined. Palatal deviated incision is very important when you have upper jaw surgery, cause of promoting flap reflection and performing the better the surgery field. Make it easier flap management. The ordinary, the incision line should be 2 millimeter, the parallel side from the ridge crest on the upper jaw. There's ordinary situation when you have a surgical field. Okay, after incision, make clear, and the flap reflection using this periosteal elevator. we can do the flap lid surgery in sort of the case, this kind of case. However, flap open and the implantation is better because of the obviously we can see the clear, the actual situation of the patient mouth, alveolar ridge, remnant of alveolar ridge, the bone spicules, and the some of defect, we can see clear. The obviously better the situation when we have the flap open, the surgery style. However, if you want, you can skip the surgery. You can skip the flap open. So the flap lid surgery will be done by the surgeon's preference. Anyway, Dr. Chung want to make a flap reflection because of these patients have a complicated situation, you know, the poor period condition and the sinus involved on the molar side. The anterior area, as you know, from the CT, cone-beam CT view, we know already have some defect around the socket area. And first of all, as you know, with this full mouth case, sometimes we need alveolar plasty, right? Just only 1 week after extraction, we can see clear the bone spicule around the alveolar, the extraction socket. So some portion need the trimming by bone launcher or some round bars, and any other instrument can be used. However, the alveoloplasty is needed. Okay. Whole extraction areas to cleaning up again. I think the ridge width, alveolar ridge width is good. Actually, not so bad. A little bit, the palatal reflection, palatal flap reflection was performed. Is starting the alveoloplasty, the removing some of bone spicule and irregularity of the bone, remnant of the bone area. This is very important, good healing process. Okay. This using this round bar have the obvious big purpose. First one, removing whole remnant of the granulation tissues and the inflammatory tissues, and another purpose is the promoting activation, the surface bone area. So the removing, the scratching and removing the surface bone, the cortical bone, and sometimes activation, to promote activation of new bone formation, right? And actually, another purpose, the auxiliary purpose, the main purpose is the removing the irregular bone spicule, removing the irregularity of the remnant of the bone, the alveolar area, and the whole the granulation tissues and remnant of the inflammatory tissues. as you can see, that is all we have. The alveolar bone situation. The width, alveolar bone ridge width is enough. Actually vertically reduced. As I mentioned before, can you remember intraoral view and the panoramic view, CT scan, the vertical height reduced, however, the horizontal width is still remaining like this situation. So we got already this kind of information from the CT scan and intraoral scan and the Rainbow 3D view. Through the Rainbow 3D view program, we can get ready these some of information, the hard tissue information and soft tissue information. Especially actually, as you know, the periodontally compromised patient case, actually, we strongly recommend delayed approach after extraction and wait 4 months, 3-4 months, and then do the implantation is better. Inside of the periodontal the condition, cause of the periodontal disease, the site impacted by periodontal pathogen for a long time. So, generally speaking, periodontally compromised area should be waited for a long time for the delayed approach. The delayed approach is better. Delayed approach is the optimal procedure. However, this patient, the full edentulous situation, cause of the whole teeth should be extracted case, and there are no more teeth remnant. So the aggressive and the subtle, the removing whole the periodontal granulation tissues and pathogen using the round bar is very important procedure before the implantation and the implant procedure. So as you know, this little bit, the labial position is original, pointed by the stent. However, Dr. Chung is modified some of the palatal areas moving for the osteotomy site, the starting point. And actually, between number 12 and 13, actually these areas not exactly same as 12 tooth area, right? As you know, between number 12 and 13, the cause of he want to use the little bit more the stable, the alveolar ridge area. Between number 12 and 13 area is better for osteotomy and implant installation. Even though the bone grafting, if we do the bone grafting procedure, it is auxiliary procedure. It is not main procedure. So we can get feel-free bone grafting after installation, right? However, if we get the implant exactly same as number 12 extraction socket area, what will be problem? What will be the risky point? First, actually number 12 tooth already infected by periodontal disease, the chronic periodontitis. So another one problem, we need a little bit more bone grafting. And if we cannot get enough initial stability, I think that the prosthetic procedure should be delayed, right? So between 12, 13 area is much better. The strategic, the positioning. Number 14, the same. Actually, between number 14 and 15, interseptal bone area is achieved for osteotomy. Okay, number 22, 23. Actually, the positioned area number 22, right? Exactly the same as number 22 area. However, Dr. Chung moving to palatal from the original pointed area. Because of little bit palatal moved installation for osteotomy is get some advantages in future restoration. Number 14, similar to the initial point. Using Lindemann drill, moving to palatal. A little bit more. And number 15 area is maybe the same. The palatal moving from the labial initial drilling point. The palatal inclined implantation is better than the labial positioning because of, the labial alveolar bone absorbed so very faster after extraction. So we have to consider bone resorption process after extraction. So this 1 week after extraction implantation, similar as immediate implantation procedure. So when you have immediate implantation after extraction, we aim the socket, the palatal area of the socket and lingual area of the socket, lower jaw. So the same as immediate implantation, even though 1 week later after extraction. So anyway, the proper positioning first, and then osteotomy was performed. The final drill have two different types, The first one is the Lindemann drill style, the final drill. Another one is traditional style. So now Dr. Chung is using the Lindemann style, the final drill. This drill have a higher efficiency of alveolar bone cutting. However, so faster and easier the alveolar bone cutting and osteotomy. So for the beginner, actually, this is not recommendable. Number 14. Drilled with a planned. The actually planning is number 14 and 15. However, the osteotomy site between number 14 and 15. And the posterior one, another one, is moving to posterior a little bit more. So between number 15 and the 16 area. So according to this drilling protocol, whole implant surface should be covered by host bone. So as I mentioned before, the bone grafting is the auxiliary part. So it is not the severe condition of a GBL procedure, like as a GBL procedure. So we can get, we feel free about bone grafting procedure, right? So very important factor for the early loading in future. So final drill, just before the installation, the actually yellow diameter, yellow banding of final drill means 3.5 diameter, you know, and green 4.0. So the anterior area, Dr. Chung have a plan about the 3.5 diameter, 9 millimeter length. Okay, number 12 area, 3.5, 9 millimeter. The bright tissue level implant was installed. So faster installation and good initial stability. Whole implant surface surrounded by host bone. And another one, number 14 area, actually between 14 and 15, and 3.5 diameter, 9 millimeter length. This implant installation protocol gave us not a serious GBL procedure, right? It's just bone grafting with a simple procedure and the suture, that's it. And sometimes we can make an open wound style, open wound healing style concept. We can expect the faster ossea integration. It means we can get the final lacerations for the patient after installation due to the actually not a serious GBL procedure. It means not involved the GBL procedure, serious GBL procedure. It means faster healing, faster ossea integration. Finally, we can get the faster final laceration. It is good news for patient, also good news for the surgeon. Number 24 area. Actually, upper left jaw, Dr. Chung insert with the diameter 4.0 and 9 millimeter. The cause of this area have some little bit wider alveolar bone with us. Removing plastic cap, and the next procedure will be connect with the healing cap. However, we need the two more implant installation, actually number 25 and number 15. Number 15 area involved with the maxillary sinus. Dr. Chung need to have a sinus the procedure. So maybe he want to have a simplified sinus procedure like a bicortical fixation or a crestal approach using crestal drill will be expected. So we are able to learn how can we use this crestal drill when you have a crestal approach or bicortical fixation. Okay, healing cap, the connected was the connected, and we need two more implant. number 15 and 25. Actually, both of them are involved with the sinus floor, and we need the sinus procedure. Dealing with the sinus floor, the menus of sinus floor using crystal drill. Hopefully I want to see using the crystal drill on these number 25 and 15 area. Before the crystal drill, he is doing the osteotomy, 3.5 diameter final drill with lower speed RPM, 50 RPM. And this RPM is good for the conserved remnant of the bone. Obviously, he wants to make expanding the remnant of the alveolar bone. The remaining alveolar bone squeezing by this drilling process. Okay, once more. 4.0, 9 millimeter. Okay, using depth gauge, he is checking the sinus floor intact or not. If sinus floor intact, it means good news, right? So we can use crystal drill for the bicortical fixation. The final, okay, the fixture is installed with 4.0, 7 millimeter. I see. Instead of bicortical fixation or the compaction of bone into the sinus cavity, instead of this procedure, he have decided shorten the fixture length from the 9 to 7 millimeter. So 4.0 diameter, 7 millimeter length of the implant was installed on number 15 area. Number 25 areas, now he is doing the crystal drilling, right? Checking the depths, okay, almost 9 millimeter. He need more for compaction. This crystal drill is very versatile and useful instrument when you have a crystal approach or bicortical fixation procedure, the sinus involved area. This crystal drill have a unique action during the clockwise drilling, the procedure with 15 RPM, 50 RPM. So the bone, the compact, the pushing into the sinus cavity, sinus floor, even though the sinus floor is broken, a little bit broken like a green stick procedure, the remnant of the bone, the wall of the osteotomy site areas, remnant of the bone, pushing into the sinus, the cavities area, the compaction and the pushing inside. So, cause of this action, the sinus floor is not perforated. So, protecting the bone chip, right? The bone chip protecting the sinus membrane tearing, and also a little bit the upward, the moving into the sinus cavity site, and no more the bone grafting procedure, just to put implant fixture into the sinus area without any grafting material, cause of already this bone chip compacted into the sinus floor area without the sinus membrane tearing. So it is unique, and the magic like the action if we use this crestal drill to have a moderate dimension from alveolar crest and sinus floor. The moderate dimension means about 5-6 millimeter remnant of the bone situation. You know the criteria under the 3 millimeter, we need a lateral approach, generally speaking, and from 3 millimeter to 6 millimeter depend on the situation and surgeon's preference. However, we recommended the crestal approach. About the 6 millimeter, the bicortical fixation is a good candidate and good procedure. The 6 millimeter remnant of the bone is good candidate for bicortical fixation. So when we are achieving the bicortical fixation, there are many the variant of method and instrument. In this time, Dr. Chung showing us this crestal drill usage. And whole implant fixture was done. 6 implant fixture was installed on upper jaw of patient, and the bone grafting procedures are started. As I mentioned before, the collagenated bone was used. First, osteogenocollagen. Osteogenocollagen means osteogenograft particulated bone intermingled with the collagen binder. Osteogeno came from bovine bone, bovine origin. And this one is osteon 3 collagen, the alloplastic graft materials. Okay, and defect filled with osteon 3 collagen. The connected defect with implant fixture filled with the genocollagen, and just a solitary defect and solitary socket filled with osteon 3 collagen. Why? Osteon 3 collagen came from alloplastic material. It is a much better and good performance with maintaining the bone volume, actually maintaining the volume. However, this genocollagen gave us a good performance about the little bit the new bone formation compared to the alloplastic osteon 3 collagen. So, induced and connecting with the implant fixture area, this genocollagen is better than the osteon 3 collagen from alloplastic material, right? And this osteon 3 collagen have a good performance maintaining the volume. However, this genocollagen getting better performance, making new bone formation, even though the small volume, without the bone, without the membrane, without the barrier membrane, right? So that is why there is big difference between two different kind of collagenated bone graft materials. So Dr. Chung is combined each other, depend on defect style and defect position. After that, this collagen graft 2, as I mentioned before, introduced before, this collagen graft materials covered the whole this bone grafting area. And this lay this put the collagen graft 2 over the grafted area. Okay. Using this long height of comfort cap, this collagen graft easy to fix. And this collagen graft material to cover whole this grafted area with a simple manner. So the suture is remaining procedure. Actually, when we use this collagen graft material, it means open wound healing concept. So you don't need the big flap reflection or the periosteal releasing incision. You don't need the big periosteal releasing incision. So if you use this collagen graft, you can skip the bigger periosteal releasing incision. Just the small the periosteal releasing incision, the minimum, the covering whole this area is necessary, is enough actually. However, let's see if you use the barrier membrane and the graft materials, particularly the graft materials with the traditional concept of GBL procedure, you should primary procedure. You should perform the primary closure. So you need wide and big periosteal releasing incision. So it is another trauma to your patient and another trauma for this surgical field, surgical area. So, the swelling and the delayed breathing and sometimes ecchymosis, and there are many discomfortness will happen with your patient. So this kind of surgery concept to reduce all this discomfortness after surgery. A perfect installation with position and depth, and perfect tissue management with an easier manner. Yeah, I think even though the big surgery, the procedures extremely simplified and minimized and maximize the result. Okay. Checking the buccal flap adaptation and the suture. Actually, underneath grafted material, protected by 3-layer collagen. First layer from the inside, actually, osteogenocollagen. The collagen from osteogenocollagen, right? Number 2, second layer, osteon 3 collagen. The collagen layer from osteon 3 collagen, right? Finally, this collagen graft also composed of the collagen matrix. So 3-layer collagen layer of protection underneath grafted area, grafting material. So I think it is enough protection for the underneath grafted bone grafting material. Today, actually, I'm so happy because of I want to see the proper usage of a crystal drill. This crystal drill actually having adjustable the stopper style, the versatile devices for sinus surgery. And Dr. Chung shown us about this number 25 area. Yeah. Now he is suturing whole reflected flap for the primary. Some part will be achieved primary closure, and some part just open healing style, the leaving it, and the fast epithelialization will be performed when you use this collagen graft combined with the PDRN. Especially PDRN is another good resource promoting the soft tissue healing. We can get better soft tissue healing when we use PDRN, soft tissue healing material, promoting the soft tissue healing material. I expect after all this surgery procedure, Dr. Chung inject PDRN this surgery site. If you don't have PDRN, don't worry about it. Just leave it like this situation. The cause of collagen graft, even though the exposed area, exposed collagen graft, to promote faster healing of soft tissue, make faster epithelialization on this exposed area. Don't worry about it. The same as the open wound healing concept. Okay. It was done the right upper jaw area. So actually 1 or 2 stitches are needed for finishing today's surgery. The suture material is 50. The ordinary 50 suture material is popular for sinus the GBR procedure or implant surgery. Okay, moving. He is moving to upper left. Once again, I'm going to summarize today's surgery. First, the digital helping us for the complicated case like a full edentulous mouth or some compromised case. Why? How? Actually, the vertical dimension setting up and the proper positioning with the full mouth, edentulous area, the surgical stent, we can get easier way by using the digital, the program. So actually before the surgery, we have some study about the digital informative, the procedure for getting proper procedure, proper positioning, and the final processes, right? And when you have a surgery time point, the simple implantation, the bright tissue level is better because of the smaller diameter compared to bone level implant, the strong connection, the strong enough with the bigger size of the bone level implant fixture. Even though the smaller diameter, this tissue level of bright system is the same as a bigger diameter of bone level implant, and simple and easier installation using the easier surgical protocol. And sometimes we can use crystal drill when the sinus involved area. And whole this installation procedure was done finally. Okay. Then after that, the prosthetic procedure also the easier and simple cause of we get ready whole information about the patient mouth and reference point of the patient. The middle line and the occlusal plane, and the soft tissue position. The whole informative reference line and reference point was achieved by using the program, the digital procedure, right? So in future, the temporization and final restorations followed by these the achieved information from the digital procedure. I think a digital procedure, like as an exam study. Before the examination, we all have the same experience, the hard working, no sleep, no eating, just studying for the passing the examination or getting a higher rank of the score. So this digital, the procedure is the same like as exam study, right? Before the surgery, we can see whole procedures in the cyber status on the programming. We can adjust the position and depth of pictures and the vertical horizon, the polar position and the angulation, the diameter length, all of these informations achieved and adjusting. And then the final result was achieved with the surgical stent. And when you have a surgery time, it just adjust and the adaptation surgical stent and the drilling with the protocol, right? The hard working before exam, we can get the good score when we have an examination. The same as the exam study. The digital procedures are very informative and worthy procedure. Okay, almost done. The little bit adjusting the position of implant fixation. However, the whole procedures was done like a textbook, like the perfect insertion, the perfect positioning, the perfect initial stability, and the soft tissue management. Okay, after that, the actually normal procedure will be intraoral scanning for getting information, the soft tissue and the positioning of implantation. This comfort cap working as this digital scanning jig, The comfort cap have a dual function. First one working as a healing abutment, another one the impression jig, the digital impression jig, right? So after surgery, just intraoral scanning, getting good information about all these soft tissues and the fixture position. And after that, we can get easily the temporarization, temporary PMMA prosthesis with abutment. That's a big benefit. That is all we have when we have a digital procedure. The big benefit combined with a simple and easier procedure after surgery. Actually, procedure, whole this prosthetic procedure in future is the simpler and easier. According to the achieved information, we made the PMMA prosthesis for the temporarization with the proper vertical height and proper positioning, with the proper midline, with the proper occlusal plan, and proper the shape. All of these important considering factors achieved with the easier manner due to digital procedure. Okay. Hopefully it should be a last suture. Okay. Surgery was done perfectly. Another one thing I want to mention about this collagenized bone is the osteogeno collagen and osteon 3 collagen. It makes it easier with the bone grafting and GBR procedure. Okay, now the PDLN injection was performed around these surgery areas with the bone grafting, right? This PDLN, the promoting the soft tissue healing, the faster soft tissue healing. Okay. Yeah, the collagenized bone is very versatile and useful bone grafting materials. Another shape of grafted material. So this one is the easy molding and the easy application, like sinus area. And also today's surgery shown us about the double layer, geno and the alloplasty. Okay, the surgery was done, and we will have a 10 minutes break, and I will be back in 10 minutes. Stay tuned. See you. Thank you. Okay, thank you. Let's see after post-op result. This pen view shown us a very perfect and good result, good situation after installation. Number 245, both of upper jaw, maxillary area installed with bright tissue level, 3.5 diameter, 9 millimeter. And the number 15 area, actually bicortical fixation with a 7 millimeter implant installation. Number 25, 9 millimeter with crystal drill, as I mentioned before during the surgery. Okay, the cone beam CT view, the perfect, the beautiful situation. As I mentioned before, number 15, 14, 12 areas installed with number diameter 3.59 millimeter, both of 12 and 14, and 4.0 diameter, 7 millimeter of number 15. And the left side of upper jaw, 22, 24, 4.0, 9 millimeter, 25 area, actually 4.5, 9 millimeter with the crystal drill, a little bit more, longer than number 15 area, cause of this area have abundance of the remaining bone and the crystal drill usage. I think all of these pictures are very nice, well done, installed with the initial stability, cause of whole surface surrounded by host bone is very important factor and advantageous, and connect with the healing cap, comfort cap for dual function, scan jig, working as a scan jig, and the healing abutment, healing for healing. And after this surgery, this patient taken by a rubber impression using this 3D printed denture. This 3D printed denture from this digital procedure, this denture, the working as using as an individual tray for patient, and exactly perfect the negative impression the bodies from this procedure, upper and lower. So this negative rubber impression scanned by the model scanner, and we can get the STL file, the images from the negative impression scan data, and also the stitching with a CT STL after surgery. So both of these information, the merging each other, the stitching each other from the scan, from the impression negative area, negative mold, and the CBCT, CT STL. So finally, we get the perfect situation for the patient in future prosthesis. From all of this data we can get this temporary PMMA, very nice, beautiful PMMA temporary restoration from whole of this digital procedure after surgery. Okay, finally, this digitalized, this PMMA temporary restoration delivered to our patient mouse. Actually, as I mentioned before, whole implant fixtures get the higher initial stability for the proper positioning, good positioning, and good installation procedure. So this immediate implantation, immediate prosthesis will be done for the provisional restoration delivered. Actually, provisional restoration delivered after 1 week, 1 week after surgery. Okay, so whole of procedures are wonderful and perfect and beautiful. So I am very happy, and actually, patient was happy too. Okay, here is a good question about some of material about the osteon collagen and osteon 3 collagen. What is big difference? What is a difference? And what are the advantages of each product? Actually, first of all, osteon 3 collagen, about launched several years ago. Actually, these osteon 3 collagen have a lot of clinical evidence during several years ago, several years. So this osteon 3 collagen working as a good activities performance for the maintain the volume, the rich volume, the maintaining is higher performance of this osteon 3 collagen compared to other grafted graft. The collagen is the graft. Why? Actually, osteon 3, as I mentioned before, many times introduced about this collagenase product, the alloplastic. Alloplastic graft materials, the bone formative function is lower than autogenous and xenograft. However, the maintaining volumetric function is higher than any other product. So if you want to have maintaining or augmenting volumetric situation, you have to choose osteon 3 collagen, right? And this osteon 3 collagen have actually 10% porcine collagen included, and the 60% HA and the 40% beta TCP combined each other. Actually, and these alloplastic materials. And about osteon collagen, these graft materials, particle from bovine bone, and 8% porcine source collagen holding this bovine particulated bone. So generally speaking, you know, the xenograft higher the performance than the alloplastic, right? So this osteon have a good the bone formative function, and also this 8% collagen, the binder, gave us easy molder and easy molding and stay there. The key factor of GBR, successful GBR procedure, you know, actually the stability and the fixation is very important factor, you know. So these 8% collagen holding materials gave us a good performance, higher performance of these bone grafting materials on the surgery site, right? So sometimes we can skip some of fixation instrument, fixation protocol, like suturing or the pin fixation. So we can skip in some of situation when we choose this collagenated material, right? So that is my answer. So if you want to have a little bit more bone formative function, if you want to have a higher, want to have a bone formative function, you have to choose osteon collagen. Bone maintaining bone volumetric volume maintaining function, you have to choose osteon 3 collagen. For me, actually, I have a double layer technique. Inside, actually, exposed implant or inside the area, put the osteon collagen instead of the particulated bone, and outer surface, outer side covered with osteon 3 collagen. It is my recipe for maintaining the volume and human formation. However, this xenograft will be reduced the volumetric measurement after 3, 4, 6 months later, you know. So to compensate this reduced volumetric resources, I use osteon 3 collagen. Okay, thank you for watching. Thank you for watching today. Next